All right, let's unpack this. Today, we are going completely past the headlines. We're going straight into the actual documentation of clinical
All
practice.
right, into the source material.
Exactly. We are taking a deep dive into the high acuity surgical environment at AIMS Nagpur in India, and we're using the most raw, I think, and detailed material you can get.
Well, yeah, these are real-world admission notes, operative logs, pathology reports.
And even the formal quality control protocols that the general surgery department uses. So, this isn't some theoretical discussion.
No, not at all.
Yeah.
This is a look at the life or death decisions being made every single day in a major high-volume public hospital.
So our mission here is really twofold. First, we want to synthesize these documents to map out just the extraordinary breadth and depth of modern surgical challenges.
And that means moving from the routine, which is still complex, all the way to, well, catastrophic emergencies.
And second, to really understand the critical systems that they put in place. Things like quality surveillance, to manage the inevitable risks that are just inherent in this kind of high-stakes work.
Absolutely.
We are navigating everything from like scheduled cancer resections to massive trauma cases and those brutal post-operative battles against multi-drug resistant infections.
And, what's really crucial here is that we have a clear anchor for the high acuity work we're looking at.
Okay.
The depth of this clinical narrative, it lets us see not just the procedure, but the whole context.
The bigger picture.
Exactly. The pre-existing systemic disease, the immediate post-operative struggles, and, the pathology results that ultimately tell you what the prognosis is.
And to really focus our lens, we found a specific anchor point.
We did. We noted the explicit involvement of Dr. Senthil Kumaran, who is a prominent surgeon there, in one of the most demanding vascular emergency cases in our files. This was from November 2024.
And what was the case?
It was an emergency right above knee amputation combined with embolectomies for systemic clotting. I mean, this case really serves as a touchstone for the level of complexity we're about to explore.
So these notes, they're not just records. They're the clinical narrative of exceptional surgical demands.
That's the perfect way to put it.
All right, so let's start broad. Let's start with the sheer scope of the general surgery workload at AIMS Nagpur.
It's immense.
When you look at the compiled diagnosis and procedure lists, the department's ability to just pivot between elective, specialized, and emergency work, it shows an incredible level of comprehensive capability.
It really does. It's a kind of adaptability that you might not even expect in such a highly specialized environment. General surgery in this context really means being a master of multiple domains.
So what grounds the department? What's the day-to-day?
Well, on one hand, you have the foundational work. These are the elective procedures that, if you do them efficiently and safely, they sustain the department.
Okay, like what?
We see a huge volume of laparoscopic cholecystectomy for gallstones cholithiasis, as it's called. This is a common, often day-case procedure, but it requires incredible precision and organization to do at scale.
And I saw a lot of hernia repairs listed. That's got to be equally foundational.
Precisely. You see the whole spectrum of abdominal wall defects, inguinal, umbilical, incisional hernias. But what's really interesting is that the documentation points to a preference for modern, minimally invasive techniques.
So not just open surgery.
Not at all. Many are managed laparoscopically. You see total extraperitoneal repair, or TP, and transabdominal peritoneal repair, TAPP, mentioned frequently.
Is there an example that stands out?
Yeah, there's a case of a 72-year-old who was managed with a TPP for a complex bilateral pantaloon hernia. Using these kinds of advanced laparoscopic methods for what are, routine cases, it suggests a very high technical standard within the unit.
And beyond that?
The workload is also grounded in excisions for benign masses. Things like fibroadenoma in breast tissue or removing lipomas. These are your standard, bread and butter cases that really underpin the daily surgical schedule.
But what's so fascinating here, and I think this is where we really need to dig in, is how often that routine surgery becomes, well, anything but.
Because of the patient's existing health profile.
Exactly.
That is the critical insight from these documents. The comorbidity burden is just staggering, and it dramatically elevates the risk of even the most basic operation.
What are the big ones you see over and over again?
We are repeatedly seeing type 2 diabetes, mellitus T2DM, hypertension, and chronic kidney disease, or CKD, intersecting with the need for surgery.
And these aren't just minor footnotes in the chart, are they?
Not at all. They dictate the entire management plan. and often they're the reason the disease has presented so aggressively and at such a late stage in the first place.
So give us an example. How do these chronic conditions escalate what seems like a localized problem into a major surgical event?
I think the most immediate and stark example is the crisis created when you combine severe diabetes and peripheral vascular disease.
Okay.
We see a really high frequency of diabetic foot infections and cases of necrotizing fasciitis. These require urgent, aggressive debridement, and very often they lead to amputation.
So a small wound becomes a lost limb.
It can. Sometimes it's a minor amputation, like we saw with a 61-year-old patient who had hypertension,
Sure.
CKD, and a prior stroke. He needed a great toe amputation. But, as we'll discuss, it often leads to major limb loss. Diabetes essentially turns a simple wound into a life-threatening, limb-threatening emergency almost overnight.
Wait, let's pause on that case for a second. If the patient already has CKD and a prior stroke, that amputation is no longer just about removing infected tissue, is it?
Not at all.
It's an immense physiological stressor on an already failing system. So how much of the surgical team's time is spent just getting these high-risk patients cleared and stable enough for the operating room?
An immense amount of time. And that's where the multidisciplinary approach becomes completely non-negotiable. The notes are just full of consultations and clearances from other departments.
It's a team sport.
It has to be. We have cases where the cardiovascular risk alone just stops the clock.
Hmm.
For instance, consider a patient scheduled for an exploratory laparotomy for acute intestinal obstruction AIO.
So a bowel blockage.
Right. But this isn't just a simple blockage. The patient also has ischemic heart disease, a documented regional wall motion abnormality, meaning part of the heart isn't pumping correctly, and a mildly impaired left ventricular function. Their ejection fraction, or EF, is only 40%.
And for our listeners, an EF of 40% means their heart is already struggling significantly to pump blood, right?
Exactly. A normal EF is above 50–55%.
Sure.
So before a surgeon can even touch the abdomen in this case, the cardiology team has to sign off.
And that sign-off isn't just a rubber stamp.
No, it's a detailed, strict plan for fluid management, for blood pressure control, and for mitigating the anesthetic risk. The surgical team has to be absolutely certain that the patient can withstand the stress of general anesthesia, the fluid shifts, the blood loss, all of it.
Because if the heart fails on the table, nothing else matters.
Nothing. And this complexity pops up everywhere. Even something as common as cholelithiasis gallstones can suddenly require a hematology consult if the patient has a sickle cell trait, which one of our sources notes.
Why is that? What's the risk?
That trait demands very specific anesthetic precautions to prevent a sickling crisis, a vaso-occlusive crisis, during the surgery. It adds a whole layer of risk and complexity that is completely invisible in a standard case.
So the need for this kind of systemic support is constant. Who else is permanently on speed dial for the general surgeons?
Oh, nearly everyone. Nephrology is involved constantly for managing acute kidney injury, or AKI, which frequently complicates sepsis or shock. They're also managing conditions like uremic encephalopathy.
And what about the mental health side? These are life-altering events.
For sure. Psychiatry is often consulted for complex patient management. That can be for coping with a life-altering diagnosis, managing a substance use disorder, or dealing with the disorientation and delirium that's common in the ICU psychosis.
And I imagine the lung specialists are crucial.
Absolutely.
Mm-hmm.
Pulmonary medicine is integral, especially in managing the severe respiratory failure, ARDS, that so often follows a major systemic insult like sepsis or massive trauma. You have to think of the general surgeon as the quarterback, but the entire medical hospital is the team.
And we should touch on the specialized work, too, beyond the general abdominal cases. The department also handles significant oncology work.
Yes, and this is highly specialized planned surgery. It's a whole different workflow.
What specific types of specialized oncological procedures do we see popping up frequently enough to be a core part of their work?
We see a real concentration in head and neck and breast surgery. For the thyroid, there are tubal thyroidectomies for large colloid goiters. In the parotid gland, they're performing superficial parotidectomies for masses.
That sounds incredibly delicate.
It is. It requires very careful management of the facial nerve, and these masses can range from benign, like a pleomorphic adenoma, to aggressive cancers like mucoepidermoid carcinoma.
And for breast cancer.
The scope there is wide. It ranges from simple excisions for a fibroadenoma all the way up to major oncological resections. We see modified radical mastectomy, or MRM, for locally advanced disease.
And also more modern approaches.
Yes, and increasingly breast conservative surgery, or BCS, for earlier stage tumors. These cancer cases require preoperative biopsies, detailed radiological staging, and guaranteed postoperative care planning.
Which means coordinating with a whole other set of specialists.
Exactly. You're coordinating constantly with medical and radiation oncologists. It really showcases the comprehensive cancer care that's required at an institution like this.
Okay, let's transition now. Let's move from the broad scope to the most critical, highest risk interventions documented.
The emergencies.
The emergencies, the cases where a patient is crashing and immediate surgical intervention is needed to save a limb or, to save a life. And this is where we can really focus on the work associated with Dr. Senthil Kumaran and his team, specifically in that complex vascular trauma case from November 2024.
Yes. This specific case it's a profound, incredibly illustrative example of acute systemic circulatory collapse.
So break it down for us. What was the patient's profile?
The patient was a male with a history of chronic tobacco use and occasional alcohol consumption. So, underlying risk factors that contribute to vascular damage.
And how did he present?
He presented suddenly and dramatically, complete paralysis and loss of sensation in both lower limbs. This was accompanied by what's called LMN-type bladder complaints, which indicates potential spinal cord or severe nerve root involvement, likely due to a lack of blood supply.
So immediate bilateral limb ischemia. That sounds like an agonizing surgical race against time. What on earth was the cause?
The cause was peripheral vascular disease, PVD, that had progressed to an acute crisis, an infrarenal aortic thrombus, a massive clot in the aorta below the kidneys.
How was that confirmed?
It was confirmed by a CT aortogram
Mm.
and the scan. The scan was terrifying. It showed this massive clot in the infrarenal aorta, which was leading to aortoiliac occlusion. The right lower limb arteries were completely non-opacified.
Meaning no blood flow whatsoever.
None. Zero. Just a complete cutoff.
And if a clot that big originates in the aorta, it's rarely just a localized problem, is it? The body's effectively showering itself with smaller clots.
That is the devastating reality of this situation.
Mm.
And the imaging confirmed this systemic failure. The CT scan didn't just show problems in the legs, it revealed splenic infarcts, dead tissue in the spleen, and multiple renal infarcts involving both kidneys.
So major organs were dying.
They were. And there was a specific mention of involvement in a congenital horseshoe kidney, which just adds another layer of anatomical complexity. This wasn't just limb ischemia, this was a global embolic event, likely originating from the aorta or even the heart, and it was hitting major organs simultaneously. The patient was already in systemic failure before the surgery even started.
So the surgical strategy in a moment like that, it must have been incredibly high risk and complex. You're trying to achieve multiple, almost contradictory goals at once.
It was an all-hands-on-deck situation. The surgical strategy had to prioritize life over limb on the most severely affected side, while simultaneously attempting to salvage the other.
So what did they do?
A right above knee amputation, an AKA, was performed. The right leg was beyond saving due to irreversible gangrene. At the same time, they tried to clear the systemic clot load by performing a right femoral stump embolectomy and a left femoral embolectomy.
So they're amputating one leg while trying to pull clots out of both.
Yes. They were aggressively trying to remove clots from the major vessels of both legs to restore flow, working against the clock to limit the extent of tissue death everywhere else. It's a massive undertaking.
But despite this massive coordinated intervention, really the pinnacle of emergency surgical effort, the systemic damage was just too much.
It was. Unfortunately, no, the patient did not survive. The widespread embolic disease, the massive reperfusion injury that happens after you restore blood flow, and the resultant systemic failure.
Yeah.
It was all just overwhelming.
And the final cause of death?
The patient's final outcome was death due to ARDS, acute respiratory distress syndrome, severe AKI, or acute kidney injury, and persistent profound coagulopathy, where the blood can't clot properly.
And this is the case, as you said, anchored by the involvement of Dr. Senthil Kumaran and the team. It showcases the tragic reality that sometimes even maximal surgical intervention cannot overcome the severity of advanced systemic disease.
It's a battle fought against a massive physiological collapse, a true cascade of failure.
That deep dive into the aortic thrombus case clearly establishes the systemic nature of PVD. Let's connect this to another major vascular emergency we saw in the files, one that really reinforces that the patient's heart condition often dictates the outcome of the limb surgery.
Yes, the case of the left above knee amputation, or LAK, performed in October 2024, offers a really chilling comparison.
What happened here?
Here, the patient had progressive left lower leg PVD, which necessitated the amputation. But the dominant factor driving the risk, the thing that overshadowed everything, was the patient's underlying heart condition.
Which was?
Severe dilated cardiomyopathy, or DCM, atrial fibrillation, or AF, and congestive cardiac failure, CCF, a trifecta of severe heart problems.
Okay, so just to break that down for you, that means the patient is completely unstable from a cardiac perspective. They're prone to throwing clots because of the AF, and they're already overloaded with fluid because of the heart failure. Managing their blood thinners must be a terrifying tightrope walk.
It's exactly that, a razor's edge. The patient's severe PVD led to rapid gangrene, resulting in the LIKA, but post-operatively, they developed vomiting with blood hematemesis,
That bleed.
a major bleed, and this immediately signaled bleeding complications, forcing the cardiology team to urgently advise reducing the dose of LMWH, that's low molecular weight heparin, a blood thinner, to control the bleed.
But at the same time, the vascular surgery team needs that anticoagulation to prevent new clots from forming.
Precisely. You have two essential life-saving needs: stop the bleeding and prevent the clotting, and they're working directly against each other. It is an impossible clinical dilemma.
And in this case, that high-risk gamble just didn't pay off.
It didn't. Despite the adjustments, the patient deteriorated rapidly. They entered sepsis, then septic shock, which ultimately led to a cardiorespiratory arrest and death.
So what's the takeaway here?
It just underlines a crucial insight we can gather from these files. When PVD requires amputation, it is seldom the surgical technique that fails. It's the patient's underlying severe comorbidities, especially their cardiac function, that really reserve the final say on survival.
Before we move on from these limb loss cases, there's one more I want to look at. It's a case where the complexity wasn't driven by vascular disease, but by an insidious malignancy, which was then complicated by infection. This shows a whole different axis of high acuity work.
Yes, this is the patient who presented with a very unusual, gradually progressive, cauliflower-like growth on their left foot heel.
Not a typical presentation.
Not at all. Clinically and radiologically, the suspicion was very high for a malignant neoplastic etiology, a cancer with probable invasion into the calcaneum, the heel bone.
So what was the plan?
A below-knee amputation, a BKA, was the planned definitive intervention to ensure they got clear surgical margins around the tumor.
In a high-volume center, even a planned, necessary amputation like this is still a major operation. What was the post-operative setback here?
The setback came on post-operative day 8. Despite the complex surgery going well, the patient developed pus discharge from the suture line, an infection.
And did they identify the bug?
They did.
Ah.
The subsequent culture was crucial, and it identified Proteus.
Why is that significant?
Proteus is a formidable gram-negative organism. It's particularly notorious in chronic wounds and infections, and its presence demands aggressive, targeted antibiotic therapy and often re-exploration of the wound or very aggressive wound care.
So this is a perfect illustration of how high-stakes ablative surgery, even when it's for a curative intent, can be immediately compromised by an aggressive, often resistant infection.
Exactly. An infection acquired either in the hospital or the community that requires this massive, resource-intensive wound management during what should be the critical recovery period.
Okay, now let's delve into the core of abdominal general surgery. This is where trauma, infection, and malignancy often overlap in the most catastrophic ways.
It is.
And the source documents contain one of the most demanding case narratives I think we've ever encountered. The patient who suffered from corrosive acid poisoning. We need to spend some significant time on this because it's just a textbook example of multi-system failure.
It truly is a multi-month siege. The initial event was the ingestion of a massive quantity of acid. It was Harpic, about 300 milliliters, while the patient was under the influence of alcohol.
And the immediate consequence.
A Zargar Class 3A esophageal and gastric costic injury.
Okay, for our listeners who might not be familiar with the Zargar classification, why is Class 3A so devastating?
Well, the Zargar classification ranks the severity of a caustic injury, a chemical burn. Class 3A means you have localized necrosis. The tissue is dead and burned, but it's not yet transmural.
Meaning it hasn't burned all the way through the wall of the esophagus or stomach yet?
Correct. But the depth of that injury guarantees severe scarring or stricture later on, and it immediately triggers an overwhelming inflammatory response in the entire body. It's the highest level of injury where immediate perforation isn't certain, but you know the systemic damage is guaranteed.
And was it?
Oh, this systemic damage was immediate and absolutely devastating. The patient immediately crashed into hypovolemic shock, requiring massive fluid resuscitation. Their respiratory system failed, demanding controlled mechanical ventilation. The metabolic insult was profound severe metabolic and lactic acidosis, and this all rapidly progressed to multiple organ dysfunction syndrome, MODS.
And the document notes highlight the severe impact on the kidneys and the clotting system specifically.
Yes, they developed acute kidney injury, AKI, so severe they required continuous renal replacement therapy, CRRT, and later maintenance hemodialysis. And compounding all of this was severe coagulopathy.
Their blood couldn't clot.
Right. It was evidence of disseminated intravascular coagulation, or DIC, with D-dimer levels soaring as high as 13.47. This is a body that's struggling to clot and simultaneously shedding clots elsewhere, leading to widespread vascular damage.
Okay, wait a minute. I really need to connect the dots here because this is astonishing. A massive acid burn in the stomach leads to kidney failure, respiratory failure, and eventually the necessity for a lower limb amputation. What is the physiological link between swallowing acid and losing a limb?
That is the crucial insight of this whole case. The link is shock and systemic inflammation. The massive shock and the body's over-the-top inflammatory response cause widespread microvascular thrombosis, tiny little clots forming in the small blood vessels all throughout the body.
So it's not one big clot like in the PVD cases.
No, it's death by 1,000 cuts, systemically. The patient's systemic collapse created the perfect storm for gangrene to develop in the extremities. Identical in outcome to the PVD cases we just discussed, but driven by a chemical burn and shock rather than chronic atherosclerosis. And this required a right above knee amputation on March 23rd, just days into their hospitalization.
So the surgical interventions here were just sequential, responding to the patient's body falling apart piece by piece.
Exactly. The surgery was reactive and highly individualized to the crisis of the moment. For instance, they couldn't perform an upper GI endoscopy to precisely assess the esophageal damage because the tissue was just too fragile.
The risk of perforation was too high.
Far too high. So to ensure that the damaged esophagus could rest and heal, and to provide nutrition to a body that was under immense stress, they performed a feeding jejunostomy, or FJ, a few days later. This lets you feed directly into the small bowel, bypassing the stomach and esophagus entirely.
But the battle just continued relentlessly from there.
It did. The FJ tube later occluded and required a surgical refashioning. Furthermore, the patient's prolonged immobility in the ICU, coupled with their systemic fragility, led to severe pressure injuries, which required surgical debridement of a massive grade 4 bedsore.
And the infection battle in this patient was particularly aggressive. I saw a note about the suspicion of gas gangrene.
Yes. A CECT scan revealed air pockets foci deep within the muscle compartments of the right thigh. Clinically, this is highly suggestive of gas gangrene, which is likely caused by Clostridium perfringens.
And that is a particularly nasty bug.
Extremely virulent, a flesh-eating bacteria. This finding forced the clinical team to make a huge, immediate shift in their antibiotic strategy. They had been using a robust empiric regimen of meropenem and teicoplanin, but they had to stop that immediately and escalate.
To what?
To ceftazidime-avibactam, which is a powerful combination used to combat highly resistant gram-negative organisms. This level of rapid, responsive antibiotic cycling just highlights the constantly evolving and, frankly, desperate nature of critical care in multi-organ failure.
Okay, shifting gears slightly to other acute abdominal emergencies. The decision to operate immediately on a perforation versus trying to manage it medically, that is often the line between life and death.
That absolutely is.
And our sources show the deadly consequences when that acute surgical crisis meets underlying chronic disease.
The lethality of perforation is crystal clear in the case of the pre-pyloric perforation. This patient required an immediate exploratory laparotomy and a classic surgical fix, the modified Graham's patch repair.
What is that exactly?
The surgeon essentially plugs the hole in the stomach with a piece of adjacent fatty tissue, the omentum. It's an elegant solution. But the patient suffered from severe underlying alcoholic liver disease, ALD, which was evident through significant hyperbilirubinemia and likely clotting issues.
And the outcome.
Despite the technically successful surgical repair, the patient deteriorated rapidly and died on postoperative day 0. The documented cause was aspiration pneumonia and the existing severe hyperbilirubinemia.
So the surgery was a success, but the patient died.
The point here is that the systemic damage from the underlying alcoholism, the failed liver, made the patient completely unable to withstand the trauma and stress of acute surgery. The ALD had already set the stage for systemic collapse, making the acute perforation unsurvivable.
There's another case that shows a deadly synergy, the one with abdominal tuberculosis.
Yes, the case of acute perforation peritonitis caused by abdominal tuberculosis or Cox peritonitis.
Wait, perforation caused by tuberculosis? That sounds highly unusual in a Western context.
It is, but globally, it remains a significant cause of an acute abdomen. This patient had active pulmonary and abdominal TB, which led to multiple small bowel perforations and widespread peritonitis. This is an immediate surgical catastrophe.
So an emergency
An
operation.
emergency exploratory laparotomy, primary repair of the holes, and a proximal loop ileostomy to divert the stool and protect the repairs.
Given the massive infection load from both the TB and the bowel contents, this patient must have been in severe septic shock.
Overwhelmingly so. The notes indicate the severity of the septic shock and the coagulopathy. The patient required 4 units of fresh frozen plasma, FFP, preoperatively, and then a staggering 8 units of FFP postoperatively, just to manage a severely deranged INR and clotting issues.
And even that wasn't enough.
No. Despite this massive transfusion and the surgical intervention, the underlying septic process was just too advanced. The patient succumbed to septic shock and ARDS on postoperative day 4. These cases really underscore that general surgery in this setting is often managing the final, acute manifestation of severe, long-term infectious and chronic disease.
Finally, for this section, let's analyze the oncological receptions documented. Let's focus on the pathology reports because that's where the crucial prognostic insights really come from.
Absolutely. The documents on colorectal malignancies are highly instructive. Let's take the example of the patient who underwent a right hemiclectomy for a moderately differentiated adenocarcinoma.
So, colon cancer.
Yes. The histology report provides the essential data points for that patient's future. The tumor was classified as PT2, meaning it had invaded into the muscularis propria, the deep muscle layer of the bowel, but the surgical margins were clear.
Which is good news, right? It means the surgeon removed all the visible disease.
It's good news, but the devil is always in the pathological details, particularly when it comes to microinvasion.
Okay, so what were the key prognostic flags in this report?
This is where we extract the high-level insight. The report specifically noted no lymphovascular or perineural invasion. This is generally excellent news. It means the tumor hasn't overtly started traveling through the blood vessels or along the nerves to spread elsewhere. However,
There's a however.
the report did confirm the presence of tumor budding.
Tumor budding. Okay, that is a term that needs immediate explanation. Why is this tiny microscopic detail so critical in modern oncology, even if the main tumor is gone and the margins are clear?
Tumor budding is defined as single tumor cells, or small clusters, up to 4 cells, that have broken away from the main tumor mass and have invaded the stroma of the surrounding tissue.
So they're like little scout parties.
That's a great way to think of it. While it sounds small, it is now recognized as one of the most powerful and independent indicators of a poor prognosis in colorectal cancer. Even if the lymph nodes are clear, what we call N0, high-grade tumor budding significantly increases the risk of recurrence and metastasis.
So for you, the listener, the key takeaway is that this single pathological finding instantly moves the patient into a much higher risk category.
Completely. It often dictates the need for more aggressive chemotherapy postoperatively, even in what seems like early-stage disease. It completely changes the risk profile of that patient.
And it wasn't just standard colon cancer they were dealing with.
No, we also have to briefly mention the diversity of cancers they handle. We saw documentation of a case involving leiomyosarcoma of the rectum. This is not a common adenocarcinoma, but a rare soft tissue sarcoma. It presented as a highly vascular soft tissue mass in the rectouterine pouch.
That sounds incredibly complex to operate on.
Handling soft tissue sarcomas in the deep pelvis requires a massive operative effort and typically a multidisciplinary management approach, often involving preoperative radiation. It just shows that the department's capability extends well beyond the most common GI tract malignancies.
So we've established that this combination of complex surgery and high comorbidity inevitably means there's a massive threat from post-operative complications.
Particularly infection.
Exactly. We saw it in the amputation case, the corrosive poisoning case, the perforation case. It's a constant theme. And this necessitates a robust system for tracking and controlling these infections, which brings us to the formal quality control documents we reviewed.
Infection really is the Achilles heel of high-acuity surgery. And the microbiology reports we synthesize reveal a worrying prevalence of multi-drug-resistant organisms, or MDROs.
We already mentioned the Proteus infection complicating the BKA.
We did. And we also saw Enterococcus faecalis in a patient's midline discharge following abdominal surgery. That particular bug was sensitive only to linezolid, which indicates resistance to a whole host of common drugs.
But the most alarming resistance profile we found was related to Escherichia coli. I mean, that's a common bacteria, but its resistance pattern suggests a formidable clinical challenge.
Absolutely. The pus culture from a colon cancer case revealed a pervasive growth of an E. coli that was frankly an antibiotic nightmare. It was resistant to ampicillin, resistant to ceftriaxone, which is a common third-generation cephalosporin, resistant to ciprofloxacin, a fluoroquinolone, and resistant to piperacillin tazobactam, which is a broad-spectrum combination often used empirically. Furthermore, and this is the really critical detail, it displayed only intermediate sensitivity to powerful last-resort antibiotics like imipenem and amikacin.
And intermediate sensitivity means the drug might work, but it's far from guaranteed.
Exactly. It makes successful treatment incredibly difficult and necessitates the exact type of rapid, aggressive antibiotic escalation we saw in that corrosive poisoning case. This level of resistance dictates why quality assurance moves from being, desirable to absolutely mandatory.
So this is why frameworks like the World Health Organization Surgical Site Infection or SSI surveillance protocol are so critical in a high-volume setting like AIMS Nagpur.
It's the only way to track, benchmark, and respond to these infectious threats.
Let's unpack that protocol. Why is a WHO-mandated protocol necessary? Why not just have a local tracking system?
It all comes down to standardization and accountability. If every hospital defines infection differently, you can't compare outcomes, you can't identify systematic weaknesses, and you can't truly improve patient safety.
Everyone needs to speak the same language.
Precisely. The WHO protocol mandates the use of globally recognized criteria from the CDC NHSN, that's the Centers for Disease Control and Prevention's National Healthcare Safety Network, to ensure that all the surveillance data is objective, comparable, and actionable. It turns subjective clinical observations into objective, measurable metrics.
Okay, and the protocol divides SSIs into three primary categories: superficial, deep, and organ space. Let's explain to the listener why these distinctions matter clinically.
The distinction matters because it dictates the severity of the infection, the treatment required, and importantly, the appropriate surveillance period.
Let's start with the most common one.
Superficial incisional SSI. This is the most common type. It involves only the skin and the subcutaneous tissue, and it must occur within 30 days of the surgery.
And how is it defined?
Clinically, it requires one of three things: either purulent drainage from the wound, identification of an organism by culture, or the surgeon deliberately opening the incision because of classic signs of infection like swelling, pain, or heat.
So a little redness isn't enough.
Right. The key takeaway here is that minor issues like simple stitch abscesses or cellulitis alone don't count. It must be a true infection of the wound site itself.
Then what's next?
Deep incisional SSI. This is a much more serious event. It involves the deeper soft tissues, the fascia, and the muscle layers. For patients without implants, the surveillance period remains 30 days. An infection here typically means a patient needs to be taken back to the operating room for a washout, requiring debridement and a prolonged hospital stay.
In the most serious category.
And finally, organ space SSI. This is the deepest and often the most devastating type. It involves any part of the anatomy that was manipulated during the procedure, so an abscess in the liver after liver surgery, or an infection in the space around the colon.
So it's directly tied to the operation itself.
Exactly. For example, a postoperative abscess near the anastomosis site after a right hemicolectomy would fall squarely into this category.
And the definition of these deeper infections is also tied to timeframes that reflect the clinical reality of healing, especially when implants are involved.
That's a critical point. For organ space SSIs, the standard surveillance window is 30 days. But if the patient received a non-human-derived implant, like a piece of surgical mesh for hernia or metal plates and screws, the surveillance window extends to 90 days.
Why the extension?
It just acknowledges that infections related to deep foreign material can take much longer to manifest themselves.
Now, beyond just tracking the infection after the fact, the protocol demands that hospitals assess the patient's risk before the surgery even begins. This seems critical given the severe comorbidities we've discussed in every single case. How is that risk formally assessed?
This preoperative risk assessment uses components derived from the National Nosocomial Infection Surveillance, or NNIS, risk index. It provides an objective composite score based on three major factors.
What's the first one?
The first factor is the surgical wound class. This is determined entirely by the level of contamination encountered during the procedure itself, and it ranges from class 1 to class 4.
Can you walk us through those 4 contamination classes so we can understand the spectrum of risk?
Certainly. Class 1, clean, is the lowest risk. It's an uninfected, non-traumatic wound, and neither the routine elective inguinal hernia repair,
Okay, in class 2.
class 2, clean contaminated, means one of those tracks was entered, like in a scheduled cholecystomy or an appendix removal, but it was done under controlled conditions without any unusual spillage.
And then it gets dirtier.
Much dirtier. Class 3, contaminated, involves major breaks in sterile technique or gross spillage from the GI tract. This is common in many trauma cases or acute inflammatory conditions, like a perforated appendix. And finally, Class 4, dirty infected, is the highest risk. The surgical field is already infected before you start, or the wound involves an old, contaminated traumatic injury. The debridement of a severely infected diabetic foot would be a classic Class 4 operation.
Okay, so that's wound class. What's the second factor?
The second factor is the ASA score, which is the American Society of Anesthesiologists Physical Status Classification. It's basically a measure of the patient's overall systemic health. A healthy person is ASA 1. A patient with severe systemic disease that is a constant threat to life, like that DCM patient we discussed, might be an ASA 4. The higher the score, the higher the baseline risk of infection.
And the third factor?
The third is simply the duration urgency of operation. Longer and emergency procedures inherently carry a much higher infection risk than short elective ones.
So the big takeaway for you, the listener, is that by combining these three factors, the patient's fitness from the ASA score, the contamination level of the wound, and the length of the procedure, you get a standardized objective risk score.
Yes, and that allows hospitals to compare their performance only against other surgeries of comparable risk. It makes any quality improvement efforts much more accurate and fair.
That makes perfect sense for benchmarking. But the logistics of tracking these outcomes after the patient has left the hospital must be incredibly challenging, especially in a high-volume setting where patients may travel long distances to get care. How does the protocol solve the problem of post-discharge follow-up?
This is often the weakest link in any surveillance system because SSIs frequently appear 1, 2, or even 3 weeks after discharge.
And the patient is at home.
Exactly. The WHO protocol addresses this explicitly. It requires intensive post-discharge follow-up, ideally 3 reviews within 30 days, at the end of week 1, week 2, and week 4.
That sounds like a massive logistical burden.
It is. So recognizing that patient compliance for multiple physical visits is low, especially in resource-constrained settings, the protocol champions the use of telephone check-ins.
So you just call the patient.
You call the patient,
Huh.
and you use a standardized script to ask key questions. Is there any drainage from the wound? Is there pain, swelling, or any redness or heat at the incision site? This minimizes the burden on the patient while maximizing the detection rates. The goal is to cast a wide net to capture all those infections that occurred outside the hospital walls.
And there's one more rule about implants that's really important.
Yes, just to reiterate the highest level of surveillance. If the procedure involves the implantation of non-human derived prosthetic material, that is, surgical mesh, metal screws, plates, or grafts, the surveillance period is rigidly extended to 1 full year.
A whole year.
A whole year. This prolonged follow-up is necessary because these deep hardware-associated infections can remain dormant for many, many months before they manifest as a clinical failure. The rigor built into this quality control really demonstrates a recognition of the long-term commitment that's required for patient safety in complex surgery.
So after all of that, what does this all mean? Our journey through the detailed operational logs and clinical documentation of AIIMS Nagpur. It hasn't just been a catalog of procedures.
No, it's been a portrait of resilience.
It has. A portrait of resilience in the face of just profound surgical challenges. We've seen the sheer scope of the practice, from routine hernia repair managed laparoscopically to the massive complexity of vascular reconstruction and amputation, which is the realm associated with our featured surgeon, Dr. Senthil Kumaran.
And all the way to managing systemic catastrophe from corrosive trauma and advanced cancer pathology.
The core truth that's been revealed here, I think, is the extreme physiological fragility of the patient population they serve. The intense burden of comorbidities, uncontrolled diabetes, advanced heart and kidney failure, alcoholism, it turns every single surgical intervention, no matter how routine it might seem, into a high-stakes emergency.
which often results in these devastating outcomes due to systemic failure.
And compounding this risk is that relentless battle against post-operative sepsis, which is driven by these aggressive, multi-drug resistant organisms. It makes meticulous quality surveillance, guided by protocols like the WHO SSI criteria, not just some academic exercise.
No, it becomes the essential infrastructure of life support. It's foundational.
The complexity we've detailed is evident not only in the operating room notes, but in the sheer amount of resources that are consumed. The long list of consulting specialties, the constant need for blood products like PRBC and FFP to manage coagulopathy, and the extended stays in intensive care required to battle multi-organ failure.
For every single intervention documented here, whether it's an emergency amputation for gangrene or an attempt to repair a perforation surgery, is often the final defense. It's the last line.
Which raises an essential and I think provocative question that has to extend beyond the operating room.
It does.
Given that these acute surgical crises are so often the final result of unchecked chronic disease, how far upstream can the surgical team and the larger healthcare system really push their influence?
Through things like early vascular screening, better chronic disease management, and public health education.
Yeah.
How do you mitigate these acute systemic failures before they reach the point where the only option left is a high-risk emergency intervention?
With an almost guaranteed high risk of mortality. That, I think, is the real challenge lying just beyond the scrub sink.